Hi, everybody. Thank you all for joining our webinar today. You should have received an email that has a short agenda, but the basic focus of this call will be to review the cancer survey data that was sent to our subcommittee and also the larger cancer SIG. But we're also going to have some brief housekeeping, and we do have a member that is going to review a publication. So Sarah Napke will be discussing for about 10 minutes one of the publications that was recently posted on the cancer SIG. So at this point, I'm going to turn it over first for some items with Michelle Jackson. Michelle, I was having trouble hearing you, but can you speak and I can see if we can hear you?
Yeah, can you hear me now?
Yes, you're good.
Okay, yeah, I was having some technical difficulties, so I apologize for that. Okay, yeah, so I have a couple updates to share with everyone. One quick second, again with my technical difficulties, always fun on a Monday. Okay, so the first update that I have, I had mentioned this on the last call that we had. We submitted a session proposal for NSGC this fall that would combine pediatric cancer, brain tumors, and hematologic malignancies. And I'm very, very happy to report that that has been accepted as a pre-conference symposium. So that is very exciting. We're all excited to kind of start working on this and have it take shape. So if you guys are planning to go to NSGC this year, you can definitely look out for that. I was looking for the email. I was just going to give you guys the exact title that we submitted. I think I have it right here. So the conference organizers did ask us to make a couple very minor changes. So we did change the title of our talk. It is now titled Navigating the Expanding Genetic Counseling Landscape for Cancers of Childhood, Blood, and Brain. So that will be the title of our pre-conference symposium, and we'll keep you guys updated if there's any additional updates, but we're very excited for that. Then my other update, so I am trying to plan out our webinar schedule for this year and have come up with a couple ideas, but I definitely need some volunteers to help me out. So for our March webinar, I would really like us to start having a journal club every couple months or few months, depending on what else is going on. And so I thought maybe in March we could try to do our first journal club. So anybody that's a member can pick a journal article that maybe has been very helpful to them in clinic, or a brand new article that they would like to discuss and get feedback on from the membership, you know, kind of whatever speaks to you in terms of kind of how you're encountering things for your pediatric cancer patients. And, you know, just present kind of the basics and results and things like that of the journal article itself, and then, you know, we can have a short discussion about it. So typical way journal clubs kind of go. But we haven't really done this before, so I would love to have anybody who is interested in this, please email me directly and let me know, you know, kind of what you're thinking about. If you're willing to do a journal club presentation in March, that would be fantastic. So I'll try to send out a reminder as well for anybody who wasn't able to join, but looking for someone in March to be able to do that. So, and then we'll have some more webinars and things like that scheduled. I don't want to take up too much time right now just because we've got a lot on the agenda, but I'll bring that up next month as well, kind of what we're planning for future months. I think that's it, Liz.
All right, cool. Thank you very much. And then I wanted to give the opportunity for any new members to introduce themselves, but I'm looking through the roll call. It looks like pretty much everyone I see might be previous members. But if you want to raise your hand, there's the little icon buttons where you can raise your hand. And if you would like to say anything or introduce yourself, I am happy to unmute your line. I did just want to note that we have, if you look at the email list, you will notice that we have had probably about 4 to 6 new people that have asked to be added to our list. So just make sure now that when you are sending emails that you do go ahead and include the most recent list that was sent out today. And if you would like me to send you an updated roster, I have done that, but I'm happy to resend it. So right now I'm going to unmute. There were 2 members that raised their hand, so I'm going to unmute Anna Cantor first. Go ahead, Anna. Well, I am not hearing her. I'm going to unmute Darcy Berry.
Hi, yes, this is Darcy Berry. I'm in Macon, Georgia, and I run a cancer clinic here. I'm very happy to be part of this group. Thank you.
Great. Thank you, Darcy. And Anna, I don't know if you're there. Okay. Well, I don't hear Anna Cantor. Okay, so then we will move on to the referral list, which we are updating. So basically, Cami Schneider, as you guys know, she does keep a list of clinics that are currently seeing patients for pediatric cancer indications. So just a reminder that even though I keep the general contact list, if you want clinic information to be updated, it would be great if you can reach out to Cami to update that. Also, as related to referral guide, I wanted to let you know that right now we've reached out to the heads of the cancer SIG and asked them about an NSGC marketing contact that can put our guide in the final format and NSGC letterhead. So right now we're just kind of waiting for that to happen, but hopefully soon we will have that you guys can distribute as an NSGC related document. And I think that's the only thing that I had. So I'm going to actually turn this over now to Sarah. Sarah, I have unmuted you.
Hey everyone, this is Sarah Kanapke. So a couple of things. Thanks Liz and Michelle, all great news today. I'm really excited about the pre-conference symposium. I know you all put a lot, along with others, put a lot of work into that. So it's really, really awesome. I'm going to review this a particular article that I know was circulated recently on the listserv, but I did just want to sort of give you an update about what we are calling our publications efforts work group for this subcommittee. So basically, if you have any ideas for publications, things that are sort of on your mind, that we might be able to work on as a group, or sort of get certain members who've got interest in particular topics to work together. I'm keeping sort of a running list of publication ideas along with target publications and meetings. So that is something that we can certainly circulate. I won't go through the details of it right now, and obviously we've already had some successes with NSGC coming up, but there's also our meetings. I know that some of us have presented posters or presentations at in the past, like the ASPHO meeting, the American Society of Pediatric Hematology and Oncology. You know, certainly there's some other organizations that we're sort of thinking about outside the box, like the Association of Pediatric Hematology and Oncology Nurses, and they've got a meeting and publications as well. So again, I won't go through the details of it right now, but just wanted to let you know that we're sort of keeping a list of potential target publications and meetings as they're upcoming, and really starting to try to get members of this group to sort of collaborate together to put out there, you know, all the incredible work that you're doing. So again, if you've got ideas or if you want to be part of this publications efforts work group, then certainly let me know, and we can sort of work together on brainstorming about next steps. Really, the other piece of this is that I did want to also encourage everyone that when you do have publications that come up, to maybe let us know within this group, but also to make sure that they're highlighted in perspectives when they call for you know, recent publications by members, just so, you know, we're sort of highlighting all the, like I said, all the great work that you all are doing. So with that said, I'm just going to talk briefly about this article that I think it was Lori Ballinger who had circulated it on the listserv on, it looked like maybe about February 9th. And we can certainly circulate this article again if there's interest in that, if you haven't seen it. But it was basically, the author is Ripperger et al., and the title is Childhood Cancer Predisposition Syndromes, a concise review and recommendations by the Cancer Predisposition Working Group of the Society for Pediatric Oncology and Hematology. And it was published very recently in the American Journal of Medical Genetics. So basically it is exactly what the title says, and it's a really, really valuable tool. Most of these authors are out of Germany, and like the title infers, it was really the result of a meeting that was held, and a summary basically of a lot of childhood cancer predisposition syndromes, really great resources throughout the article, such as lists of particular tumors or cancers and what conditions they may be associated with, sort of a broader list in the first table of this article. And then it also goes through select cancer predisposition syndromes. Those are sort of the more common that we might talk about, and highlights a lot of the tumors that might be seen in those particular conditions. And also a really valuable tool that sort of plays off another article that I think Kristen Zaho had circulated in the late fall, and we talked about on this call briefly. There was an article that was published regarding a screening tool that people can use by Jongmans et al. And this article also highlights those criteria and with some brief modifications. So it has the table 3 in this article talks about when to consider a childhood cancer predisposition syndrome in a patient with cancer. So it's really, really, I think, a nice summary that they have put out as a result of this meeting that was had. And it includes, lots and lots of valuable information. I think that can be valuable for our membership, but also really valuable for clinicians that you work with. I think it is written in a way that I think could be really helpful for oncologists that you might work with. So if you need sort of a quick reference, it's I think a piece that was well needed in the literature and has now been published. So I don't know if anyone else might have thoughts about the article who've had a chance to review it in detail. Certainly, again, I think Liz could probably unmute you if anyone has any additional insight about this article, but I just think it is valuable and something to bring our attention to, and something to really keep in your back pocket. A lot of this information may not be new to those of us who work in this area, but certainly a valuable reference and something that we can use as a reference piece.
Thank you, Sarah. Really appreciate you doing the summary. If anybody does want to either be unmuted, you can raise your hand, or if you want to just type comments, then I can read that to the group. It's up to you what your preference is. So I'll give a minute or two for that. Let's see. Nina, I can see that you have a question, I believe. I'm going to unmute you. Go ahead.
Can you guys hear me? Can you guys hear me?
Uh-huh.
Oh, I just wanted to say that I did read that article that you had just mentioned, and I really do highly recommend it, because as a new pediatric cancer counselor who's still trying to navigate herself through this this new specialty, it's been really helpful as a reference.
Awesome. Thank you. That's great. Thanks, Nina.
Yeah, I'm really excited just to because it seems like there are publications that like this one that are focusing more and more on pediatric cancer, and when I started in this area of practice there just really weren't a lot of references, so it's nice to see these coming available.
Absolutely.
Anybody else have any comments? Okay. I'm going to go ahead. Thank you again, Sarah. I'm going to transfer things over to Kristen. So this is Kristen Zajo, and let me make sure. Okay. Kristen, can you
hear me?
Okay. Yes.
Okay, good.
Yeah.
And is my screen showing for everybody as far as you can tell?
From my end, yes. So I'm
Okay.
gonna. Yep.
Okay. Assume yes. Okay.
Mm-hmm.
Well, thank you, Liz. So like Liz mentioned in her email, I really just wanted to go through today the results of the subcommittee survey that we had done, which, as you all remember, was meant to be sort of like a mini version of the larger survey that goes out. So I thought today we could just go through kind of broadly some of the results. This is certainly not every question that was included on the survey, and we'll go through some of them really quickly just in the interest of time. But if anyone is interested in getting a copy of the raw data and wants to help with that, that would be great, and I'm happy to share that with you, both the quantitative and the free response data. And then, today we're hoping that we can just get some ideas in terms of what to do with this information. There's lots of great information there, so thank you to everybody who participated. And then just how to present that and what will be most useful and most of interest to the group once we go through some of the data. So just to start, some of the basic demographic information, 85% of the people surveyed said they do provide genetic counseling for pediatric oncology patients. Obviously, the 6 that said no were then just taken to the end of the survey. So that's where a lot of the incomplete response data comes from. In terms of how long people have worked as genetic counselors, the majority said they'd worked more than 10 years, but then a significant number were in the 6 to 10, 4 to 6 year range. And then in terms of how long survey responders had worked in pediatric oncology, again, you can see the majority, it was less than a year, and then, several in the 1 to 4 year range, and then a few, 16% in the 6 to 10 year range. And not surprisingly, nobody had worked in the field of pediatric oncology for more than 10 years. And then other areas that providers had worked in prior to pediatric oncology, adult oncology, and then other subspecialties were also included. And so some of the other subspecialties were just what you'd expect. There were cardiology, general genetics, like general adult genetics, and muscular dystrophy clinics, someone had listed as well. And then we did get some data on how many were members of the subcommittee already. And then some of these individuals have since reached out to the subcommittee, but certainly we do have the information of those who have not. But about 60% or so were members of the subcommittee, and about 38 to 39% were not. And then we just got some information on interest in joining the subcommittee. And then I just imported one of the tables regarding some of the other administrative information that's kind of difficult to capture in this setting. But in terms of clinical FTEs for genetic counselors, the average was about 5.3, the minimum being 1 and the maximum being 31.5. And then days devoted to pediatric oncology clinics per month, the average was about 3.2. clinic days, the minimum being 0, and a lot of those respondents just mentioned that there are no specifically pediatric oncology devoted days. They're just kind of lumped into the general oncology clinic days. And then the maximum was 22. Percent of patients referred deemed appropriate for a genetics visit. So this was kind of an interesting response, I think, because of the way the question was interpreted. So that may have just not been the best worded question. I think several people interpreted that as appropriate for the genetics visit that they were currently in, and then a few people interpreted that as appropriate for a medical genetics visit referral, like maybe for a physical exam after that visit. And so I think that's probably what's reflected in the min and max that you see there, with the minimum being people interpreting that as appropriate for a medical genetics referral visit, and then the maximum appropriate for an actual referral to the genetic counselor in peds oncology. And then FTEs for administrative support, again, the average was about 1.5, minimum being 0 and maximum being 4. And then these next two got cut off, unfortunately, I can see now, but percentage of pediatric patients that were new patients was approximately 68%, minimum 20, maximum 100. And then clearly you can see below some survey respondents reported they don't see follow-up patients. The maximum was 80% of their patients being follow-up patients. The question above that is just the average wait time for a pediatric oncology patient. So again, the maximum was a little surprising, up to 2 years, but that was only one respondent. In general, the average was about 3.8 days. And then how much time on average do you spend preparing for a pediatric oncology case in minutes? The average was approaching an hour at 57.9 minutes. Minimum was 15 minutes, and maximum was 180 for clinical, or 4 to 5 hours for research. And then you can see kind of information about time booked for new patient visits and follow-up patient visits, pretty similar. And then time spent on follow-up activities. The average was about 69 minutes, the minimum 20, and the maximum, again, 180. So here just kind of summarizes how respondents reported their time is being divided during their clinic times. And so, again, not surprisingly, maximum was seeing patients. The majority of people put that as number 1. But other notable uses of time were administrative. So some people did rank that as their highest amount of time spent. And then in the other category were things like contacting other providers, discussing, attending team meetings, things like that. Okay. Oops, I'm a little crazy. Sorry about that. And this is just that same information represented visually. Again, most of the people reported that seeing patients is the majority of their time, and then administrative a close second. And then, as you can see, still a significant amount of time for working with students and teaching, and then research and other activities. And in terms of what types of settings respondents were employed, the majority, again, university medical center, and then you can see kind of from there, private hospital or medical facility, public hospital or medical facility, and then a small percentage in other realms, diagnostic laboratories, commercial laboratories. And then in the other category were things like government institutions or cancer centers that were non-university academic centers. And then among providers in university or academic settings, the majority were under the Department of Hematology Oncology or genetics, a few under the Department of Pediatrics, and then in the other category here were also Division of Genetics and Genomic Medicine, cancer genetics, or clinical trials. In terms of how many patients survey respondents were seeing per month, it was a little bit all over the board. The majority were in that 1 to 4 range, but you can see still almost a third were reporting 10 to 15 patients per month. And then, about 25% report seeing about 5 to 9 pediatric oncology patients specifically per month. And then, interestingly, the type of attending that counselors were seeing a pediatric oncology patient with, the majority was a pediatric oncologist, but a substantial portion reported seeing patients with a geneticist, and then about 15% reported that they don't see the patients with an attending. We also asked if you generally see patients with the same attending every time, or if it varies between patients, or if it's a team of physicians. and pretty evenly split between either a single attending or a team of attendings in one specialty, with a small percentage, about 15%, reporting that they see patients with a team of attendings in various specialties. And again, in terms of if it varies by patient or is the same every time, most respondents reported that they see patients with the same attending every time, but about a third, again, report seeing patients with different attendings depending on the patient and depending on the referral indication. And then we just ask questions regarding, depending on what type of physician or attending you're seeing patients with, how accessible someone with the opposite expertise, so either an oncologist or a geneticist, is to the counselor if needed. The majority for counselors who saw patients with an oncologist felt that an attending was almost always or always accessible or usually accessible, and you can see only about 3% felt that an oncologist was never or almost never accessible if needed. And then flipping that, if you're attending as a geneticist, how accessible is a medical oncologist to you? Again, the majority felt that an oncologist was either always or almost always accessible, and then from there going down, only a small percentage, again, about 3%, felt that an oncologist was never or almost never accessible. So we also asked if you initially see patients during an otherwise scheduled appointment or during a separate counseling appointment. The majority said it was during a separate counseling appointment, about 50%. Then, about 29% felt that it varies by patient, and a small percentage, about 7%, saw patients in conjunction with a regularly scheduled appointment. So maybe an appointment with another attending or their general oncology or hematology appointment. We asked survey respondents how they order tests, and surprisingly to me, the majority of respondents order under their attending, a small percentage order under the referring provider, and only about 15% report that they order tests independently. And this is genetic testing specific. Not surprisingly, everyone reports that they use the electronic medical record in their practice of some kind. We didn't specify which EMR was used, but we did ask if the institution's EMR had a dedicated place to enter family history separate from the clinic note, and pretty evenly split here between yes or no. In the NA category, most of the people who chose that answer wrote in their response that they just aren't aware of it if it does exist. We also asked just some other general questions about the utility of the EMR and about health history tools. So we asked, does the EMR have the ability to link to family health history tools? So talking about things like drawing pedigree before the visit, collecting family health information. No one was aware of that ability in their EMR, so you're not alone. And about 15% were unsure if that exists. So I just incorporated some of the free text responses that were interesting and kind of captured a lot of the themes for some of our healthcare technology questions. So for example, when we asked if there are ways when the EMR or family history tools could be improved to help your practice, you can see kind of a collection of some of the responses here. But again, a lot of the themes were being able to integrate the EMR more into clinical practice, so getting away from paper charts and especially being able to somehow integrate the family history and pedigree into the EMR. There are lots of comments about being able to edit and then re-enter the family history into the EMR without having to print and scan and rescan after you edit the pedigree, and being able to access it easily. And then again, just streamlining pedigree drawing, streamlining family history documentation, especially when you have multiple siblings or multiple family members that you're seeing all within a session or all within a set of sessions for counseling. And then I also thought it was interesting some of the comments about being able to flag patients for referral or being able to put hard stops on family history questions in the oncology setting to help with making sure that referrals that are appropriate are happening and that things aren't being missed. We also asked about using pedigree drawing tools, pretty evenly split between survey respondents as to who uses and doesn't use them. 48% said yes, 51% said no. And among those tools, I just put in kind of the breakdown of what people reported using. So the majority reported using Progeny, but about 34% used Proband and about 13% used Cancer Gene Connect. We also asked about using risk assessment software. The majority said no for Peds cancer, although some people did report that they sometimes use it for their adult patients who then they see their children. So about 62% said no, they do not. We then asked how you disclose genetic test results. So most people reported they disclosed results initially by phone, but a close second was in person. Some, about 29%, reported that they disclosed results by letter, about 14% by clinic notes or EMR, and then included in the other category were things like email for international clients, or some people noted that they don't usually have to disclose results because most of their patients already have a working diagnosis like an NF or a CMMRD or LFS. In terms of primary sources for referrals coming into Peds Onc Clinic, this was a select all that apply, so that explains some of the percentages, but everyone reported that they get referrals from hematology oncology. Most people see referrals from clinical genetics and GI. Also BMT, primary care, endocrinology, and self-referral was about 40%, which is interesting to us, I know, in our clinic, because we're looking at, this has been a question that's come up recently as to whether or not we'll accept self-referrals into our pediatric hereditary cancer predisposition clinic. So looks like a large percentage of survey respondents did accept self-referrals. And then in the other category were things like ophthalmology, surgery, plastics, orthopedics, especially for hemihyperplasia, adult oncology, and then national and international registries. And looking at where referrals are coming from, the majority of respondents said that most of their referrals are coming from inside their own health system, but about 15% reported that they're getting more referrals from outside their health system, and one respondent reported that it's about equal between the two. Most people felt confident that they are missing at least some referrals that should be coming in. So 96% said yes, they do feel they're missing referrals that that would be indicated for genetic counseling and are not referred. So when we asked reasons why we expect that is the case, there were a lot of interesting responses here. Wish I could go through all the free text responses because some of you were very detailed, which was excellent. But the majority were referring provider had lack of education on who to refer, referring provider being protective or not wanting to upset the family at a difficult time, or just not being aware of your service in general. Interestingly, nobody reported that they felt it was just that the referring provider would rather order their own genetic testing. But lack of clinic space was something that was reported in a few respondents. And then some of the interesting other answers, people selected other just because they wanted to select multiple answers. And so things that people reported were just that the oncologists especially are more focused on treating the cancer that was kind of immediately the threat to the child's health rather than ordering germline testing or trying to determine what testing should be ordered. And then just a lack of awareness of services or PEDS providers tending to want to order testing just by consulting a genetic counselor but without actually having to refer them for counseling. Or just, a few people reported just having historically not great relationships due to conflicts with physicians, and so they felt like they just were missing providers because of that. Interestingly, most people reported they felt that they do have enough genetic counselors in their pediatric oncology practice to see peds-onc patients in a timely manner. And then in terms of multidisciplinary clinics in place for any pediatric cancer syndromes, pretty evenly split again between those who did and those who didn't. So 44% said yes, 55% said no, they don't have any specific multidisciplinary clinics for individual syndromes. For those who did have specific clinics, this was a list of the ones that were listed. So anything from pancreas, GI, and endocrine, polyposis syndromes, hereditary breast cancer, and then things like VHL, CMMRD, RB, Beckwith-Wiedemann, Li-Fraumeni, NF, and inherited bone marrow failure syndromes. So we asked questions about how you've marketed your pediatric oncology services. Most respondents reported that they've had attendance or presentations at meetings. Other ways were personal communications, in-service presentations, email blasts, printed materials. And in the other category were things like attending tumor boards, attending other types of meetings outside of genetic specialties, and then word of mouth throughout their hospitals. We did ask some additional questions about administrative support, which we can go through pretty quickly, but just in general, most respondents reported they have at least some administrative support. And not surprisingly, the types of support that are provided are things like scheduling appointments, scanning, faxing, sending letters, obtaining insurance prior authorization at about 51%, and then smaller percentages for things like filing, generating pedigrees. And then most respondents did not feel that their administrative support is sufficient, so probably not surprising to a lot of you. But about 44% said that yes, they did feel that administrative support is sufficient. We asked also questions regarding follow-up after sessions. So once genetic testing results have been received, we asked, do you see mutation-positive patients annually or regularly for follow-up? The majority said that they do at 44%, and then 25% said no. And in the other category, most people just reported that it varies by case. So it depends on the needs of the family and the needs of the patient, whether or not they see them annually. And a few people reported that it just depends on what their presentation is. So if they have clinical symptoms, they might see them more regularly, whereas if they're just being monitored, they might not need to check in as frequently. We also asked if anyone sees mutation-negative patients annually or regularly. The majority do not. But again, those who selected other at 29% mostly reported it just, again, depends on the family and if additional surveillance is still going on based on family history, or if they're revisiting at regular intervals to update any options for genetic testing that have evolved over time. We asked about letter writing for patients, which I know has come up before on some of the message boards. And the majority said that they do write letters for patients, so results letters and counseling summary letters, but about 25% said that they do not. And in that 22% who listed other, most of them said, again, it depends on the family. So certain families, they will write a letter every time. Certain diagnoses, they'll write a letter every time, but really dependent on the case. We asked about writing separate letters then for patients referring healthcare provider. The majority of counselors report that they do not do that, but about 22% do write a separate letter. And in the other category here, most respondents said that they don't write a separate letter, but sometimes their referring provider, or their attending does write a separate letter to the referring provider. In terms of involvement in research protocols for patients, the majority of respondents said that they're not involved, but about a third of participants are involved in some sort of research protocol for patients. And among those 33% who are involved, most are providing information about research studies. certainly assisting with consent, serving as co-investigators, and then smaller portions involved in grant writing, and the other were things like identifying patients for clinical trials, reviewing charts, etc. We also asked about providing inpatient genetic counseling. So the majority of respondents reported that they do at least occasionally provide inpatient genetic counseling. And then in terms of pre or post-test counseling for things like genomic tumor profiling, the majority do not provide pre or post-test counseling. A few people noted at the end of the survey that they will occasionally, but it's not something that they do consistently. We asked about establishing automatic GC referral protocols in your institution, especially since we did have so many people who reported that they do feel that referrals are being missed. But so far, the majority of respondents had said they do not have a GC referral protocol in their institution or with community providers at this time. Lots of people did note at the end of the survey that they want to establish something like this, though. And then we did ask just for what types of tumors patients are referred for genetic counseling, and probably not surprising to anyone that everything on our automatic referral list was pretty highly selected. The lowest response rate was for things like hemophagocytic lymphohistiocytosis, or HLH, and then carcinoid tumors and parathyroid adenomas and melanomas people saw less frequently. We asked about offering genetic testing to children for adult onset cancer predisposition syndromes, which we all know comes up pretty frequently. The majority said yes, but only if the child is affected with the cancer. I know that got cut off, or only under special circumstances. And a lot of the special circumstances listed surrounded extreme parent anxiety or extreme family anxiety, or the child is close to 18 and there are compelling reasons to test them, or they're a very mature teenager who are well informed and there's no suggestion of coercion, or if there's a very early onset cancer in the family. And then a few people reported that they would only consider if the child already has a cancer, otherwise they recommend deferring. But if a family is insistent, and they will most likely get the testing done elsewhere, that the counselor would consider drawing. And then when we asked about age for obtaining assent, if testing is done on kids, you can see the average was about 8.2 years for assent. The minimum age reported was 5, and the maximum at which counselors would start obtaining consent was 14. And so here again are just some of the free text responses for one of our questions, which was about testing the parents of minor patients. So you test your patient, they're positive. Do you offer targeted mutation testing to the family, especially to the parents? And so the majority of respondents said that they do, but there was a lot of variability in terms of if it was within the child's appointment or if there's a separate appointment made for the parents, either to an adult clinic, or if adult patients are seen within that clinic, if they just have to have a separate appointment for that. And then we did have some respondents who said they really don't offer that service there, but they will reactively answer questions from parents and potentially refer them to an adult clinic if needed. So again, you can see kind of all over the board in terms of responses there, but lots of good information. And then again, you can see some were syndrome specific. So certainly some syndromes where there could still be implications for adults, they were more likely to test. And then again, here's just some more of the responses to that. And certainly you guys all have these slides. You're welcome to read through them, and we can talk about any of them, but certainly fascinating information we got back from everyone there.
Okay, thank you, Kristen.
Yeah, no problem.
Oh, sorry. Go ahead.
No, you're good. I was going to say, I think we're close. So, no, so otherwise, again, the kind of towards the end of the survey, the things that we were looking at were just, is there additional need for education because this is such a new subspecialty for a lot of providers? And certainly the majority said yes, not surprisingly. We looked at what would be the most useful in gaining knowledge, and everyone responded online courses and hereditary pediatric cancer would be useful, and then other things like consulting the NSGC Cancer SIG, having a national meeting specific to pediatric cancer, local meetings were also highly valued. And then in terms of what we hope the subcommittee can fulfill, educational webinars were by far the most desired, but also information on open research protocols, opportunities for case discussion, et cetera. Also referral guidelines, education materials given to providers, and guidelines for testing procedures were listed. I think that's the end, Liz. So thank you all for bearing with me through all of that information. But if there's anything you want to go back to, or if anybody has especially any thoughts about how to present this information, what would be the most useful to the group in terms of seeing it in some sort of publication format or elsewhere, we're really open to your feedback there.
Okay, really, thank you, Kristen. So at this time, we did want to give the opportunity for discussion from everybody. So we did touch base, like Kristen and I and Michelle and Sarah Napke, since she's leading our publications effort. We had discussed about next steps, like what to do with these data and ways we might present them, potentially like as a presentation at NSGC if we submit an abstract. It's obviously too late for anything like with a workshop. We might be able to present some of it in our pre-con potentially, but we wanted to give the opportunity for you guys to provide any feedback either with specific questions about the data or if you had ideas for what we might do with it next. We would just kind of like to open that up. So again, if you want to either raise your hand, I'll be looking at that, or if you want to type in anything into the chat, that would be great. Go ahead and feel free to do that now. And Kristen and Michelle, you are unmuted. And I believe Sarah is as well.
Liz, this is Sarah. I just wanted to mention something. I know that I'd also touched base with you about by email, but and I'm not too familiar with how this works in terms of selection, but how we might be able to highlight our group and maybe some of this data in perspective, like in that piece that they have about SIGs. Maybe we could even, further delineate ourselves and highlight our group in perspective in that way.
Mm-hmm. Yeah, I agree. I think that's a great idea, especially since I know at least at Case Western in my program, the students were required to read it. So it's good for incoming new grads who are going to be starting in this field too. So I think that'd be really helpful. It's a great idea.
Yeah, I can check on the publication schedule. So sometimes Perspectives gets pretty booked out, like they'll have stuff slotted, and since it's not super frequent, it can end up being like a year or something like that. But I think it's worth contacting the editors and seeing. Anybody else have thoughts or comments? Okay. Well, I'm not seeing any, but certainly if you do have them and you want to contact Kristen or any of us, feel free to do that. You can email the whole group with your thoughts or just individuals. But I think Kristen and Sarah will probably be leading most of the efforts related to this at this point. So feel free to reach out to them. Does anybody else have just any general other comments or questions they wanted to make before we adjourn? Okay. Well, I don't see anything, so with that, we will adjourn for today. And again, reach out to Michelle and follow up regarding a future webinar, and we will try to get that scheduled and on the calendar. We don't have the exact time and date booked yet, but we will be doing that. Michelle, did you have anything else to add?
No, I think that's it.
Okay. All right. Thank you, guys. Have a great day.
Thanks, everyone. Bye.